with the direction that he was pushing his patient's arm into. So that's direction of force. Gradual application of force, same thing I was talking about last week, is that he didn't just slam on the patient really hard. It was a buildup, and it doesn't have to be incredibly slow, but kind of just 1 or 2 seconds building up that pressure to the maximum force that you were trying to break your patient's hold. Observation, palpation of contraction. So you'll see when I'm doing the pec major, I'm going to actually be palpating part of that pec muscle to make sure that the correct muscle is activating, and also working to stabilize that shoulder so he's not doing some crazy like roll or anything like that, and we'll talk about that with each of the muscles. The observation for compensation substitutions, if I'm asking him to do a Pec MMT, is he starting to compensate by flexing the biceps? Is he starting to compensate by bringing in some of those clavicular portions if I'm doing the sternal portion, et cetera, et cetera. Reminding the patient to exhale during contraction. You don't want them to Valsalva. Here is probably not going to be quite as big of a deal, but when you get out into the clinic in the real world, you'll have some elderly patients or patients with high blood pressure or various other medical conditions where if they do hold their breath during contraction, you can cause a serious medical issue like a stroke or having them pass out or otherwise. So reminding your patient, say, I want you to hold, don't let me move you. Please remember to breathe while we're doing this. Something along those lines. Verbally assess for the patient's response. Any pain there? How are you feeling? Something. Interpretation of results. This is when we're going to get into the muscle grading that Dr. Parker touched on last week. 1, 2, 3, 4, and 5. You don't need to worry about pluses and minuses now. For those of you who've ever worked in a PT clinic, you might be familiar with like a 4+ or a 3- or something like that. Don't worry about that now. Right now we just want 1, 2, 3, 4, 5. 3 means that that patient can move their extremity against gravity in the full range of motion. So that's when you're determining your active range of motion. If I'm having him bring his arm up, I know he can move it against gravity in the full range of motion, so I know he's at least a 3. If he can't do that, then you need to put them into a gravity eliminated position, which for the Pec might be like a sideline position where he's supported by the table. And then you determine a 2 means they can, in a gravity eliminated position, he can move his arm through the full range of motion or whatever extremity you're testing. A 1 means they can't move it in the full range or they need some assistance. 0 means there's 0 muscle activation at all. A 4 means they can hold it against moderate resistance, and a 5 means they can hold it without breaking. So if I'm applying my maximal force, I cannot break that patient. Later on, we'll get into what that might mean in the hand, because you'll start testing some hand muscles where if I'm using all of my strength, I'm going to be able to break the hand muscles regardless of how strong you are. So then we just talk about like max resistance versus moderate resistance. But for the purposes of this practical, 3 is against gravity, 4 is against moderate resistance, 5 is against max resistance without breaking. Is that clear to everyone? Okay. So that's interpretation of results. Manipulation of gravity versus gravity eliminated. When we're in the practical, we might say your patient isn't able to move their arm in the gravity, against gravity position. What would you do at that point? And then you would have to verbalize to this. I'd put them in a gravity eliminated position. For this case, it'd be side lying. I'd have them do it this way. And then bilateral comparison, you always start with the unaffected side, same as your MLTs, gonies, everything. You're always going to start with the unaffected side so that you start with your patient's baseline. And also, clinically speaking, if your patient is coming in with a shoulder injury, you probably don't want to get them really hurt and flared up and everything, doing all these testing, all these different tests and measures on the injured side, and then say, oh, now we need to do your uninjured side. If you introduce these things on the uninjured side first, then they know what to expect, you know what their normal is, and you know what to look for once you get to that injured side. Does that make sense to everyone? Okay, questions about that before? Let me see. So if you have this either printed or downloaded on your computers or tablets, I would recommend pulling it up, practice with this. This is how you make sure you don't miss silly, easy points. So, like I was saying before, with MLT and MMT, with the Pec Major, you have the 2 separate fibers. So the first one we're going to do is sternal. So same thing, you want to make sure about 120, 130 degrees, I can't remember exactly what your book says, lining up in that line of action of the fibers. The difference is here, rather than stretching the muscle out, I actually want my patient to be bringing his arm down into that line of action. So if he's gonna kind of be, what I'm gonna tell my patient is, I want you to bring your arm down like you're putting your hand in your opposite pocket. Do you have any pain there? Can you show me, can you do that on your own? And bring it all the way back up. So he can do it against gravity. So I know, sorry?
You at least a 3.
Oh yeah, thank you. So I know he has at least a 3 out of 5 strength. So then I'm gonna have him come across. Any pain or discomfort there? Thank you. All right, I'm gonna have you, ask you to hold there against my resistance. Hold, don't let me move you, and don't forget to breathe, okay? 3, oh, sorry. Stabilizing arms on opposite shoulder so that he's not rolling. Force, you will always wanna have your force as distally as possible to get your greatest lever arm. So it's gonna be on the forearm, okay? Hold, don't let me move you, and don't forget to breathe. 3, 2, 1. Hold, 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 hold. Any pain? And so I broke him at the very end with moderate resistance, so I would say that's a 4 out of 5. Questions about that? Okay.
Are you judging how much you're giving? I think that's the kind of gray area that he is.
So the thing about MMTs is they are, we try to make them as objective as possible with our grading system, but there is always going to be a subjective component about it, because my max strength might be completely different than your max force, than what her max force, or, you know, everyone's maximum amount of force that you can give is going to change just based on your strength levels. But because he couldn't hold, as I gradually built up that pressure, he started to break. That means he is not a 5. 5 means, here, if you can go back in that position. If I'm holding here and or if I'm pulling here and he's holding, and also notice that my forearm is in that line of force. I'm not kind of like bent over, I'm not crouched. I don't have my elbow dropped trying to play like arm wrestling with him. I'm trying to maximize those lines of force and pulling him back. Does that make sense? So if he's here, hold, and I say hold, 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 and I can't break him, then to me that would be a 5. I was talking to somebody about it earlier. There's a difference between inter-related reliability and intra-related reliability. You'll get to that eventually. For this course and intensive purposes, don't worry about that. But what that means is if I test him twice, my intra-related reliability should be good. I should say that he's a 4 both times, whereas if you and I test him, you might think he's 3 and I might think he's a 4, but there's just, you have to kind of be aware of that. Does that make sense? Does that answer your question?
Yeah.
Okay.
Were you pushing that way or pulling?
So I'm pulling.
Oh.
He is, because the muscle contraction is down towards his opposite pocket, so I'm trying to get his arm up and out. So that line of force is, I'm so sorry?
Sternal or clavicular?
These are sternal.
Sternal.
Anything about that? So clavicular, for the MMT, you're actually gonna have the arm just slightly below 90 at about 60, because those clavicular fibers aren't perfectly parallel. So you're gonna have the arm about 60. Same idea though, where he's gonna kind of bring his arm up and across his body, and I wanna pull his arm down and out, but my line of force is gonna be not quite as drastic as of an angle. Does that make sense?
Yeah.
So same thing, I've explained to my patient what I'm gonna do. I'm gonna say, patient, I'm gonna have you bring your arm, you okay? Just relax. I'm gonna have you bring your arm up and over kind of like this, towards your opposite shoulder. Any pain there? Okay, can you do that for me? Good, any pain with you doing it? Nope, all right, I'm gonna have you hold there. I'm gonna pull, I want you to resist me, don't let me move you, and don't forget to breathe, okay? Same stabilization. My elbow, my line of force has changed. I would actually even probably, for this one, change my body. That's actually probably easier. But I'd still be stabilizing. My line of force is now coming this way. And say, hold, don't move you. 3, 2, 1, breathe, 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 breathe. And relax. So he's stronger there. I couldn't break him. I'd say that's a 5 out of 5. Questions about that one? Okay. Are you okay to do a couple more?
Yeah.
Which ones are next? Delta?